Hello, my name is Jenna Mendez, and I'm in JO202, and I'm going to discuss the two articles that I researched. My research consists of comparing substance abuse treatment programs for women in prison, while my other research consists of the prescribing and referral practices of methadone and barafine in U.S. prison systems. First article's title is A Randomized Experimental Study of Gender-Responsive Substance Abuse Treatment for Women in Prison. This study took 115 women from prison and randomized them into two different treatment programs. The GRT, which stands for Gender Responsive Treatment, focused on the fact that women need to have programs specifically made for them to receive the max benefits, along with getting better outcomes. The other group was placed in the original TC program. The TC treatment program was designed for males due that males dominated prisons in the past. The TC program contained positive attitudes with socialization, positive role models, and a better outlook on inmates. The GRT treatment program focused on women's trauma along with women's psychological development. The leaders learned to recognize women's coping abilities and to place no judgment on them. This was the first study conducted to evaluate if there's differences with treatment outcomes between the GRT program and the TC program. 4 models were used in the GRT program. The self model, which is a focus on the growth of the self. The relationship model, which is a focus on the roles within the family, and they learn how to build healthy relationships. The sexuality model, which is the connection between addiction and sexuality. And last, the spirituality model, which introduced prayer, meditation, and spirituality to help transform to wholeness. The results were that the GRT program was more successful in the following: on parole, reductions in drug use, they remained in aftercare longer, they were less likely to be reincarcerated within 12 months of parole. The GRT's focus on women's needs for recovery gives them a comfortable, safe environment to open up and receive better treatments, resulting in better outcomes. The second article that I went over was for methadone and barafine use in U.S. prison systems. The prison population is on a rise, and a large majority of them are sentenced for federal drug charges. Therefore, there needs to be revision of pharmacological treatment offered and provided for inmates in prison and aftercare when released from prison. There's over 50% of inmates that relapse within the first month out of prison. Therefore, offering opiate referral practices while in prison and aftercare treatment can reduce drug overdose, reduce infectious disease, transmissions, reincarceration, death, HIV, HCV, and infection. MMT is methadone maintenance therapy that helps treat chronic heroin addiction. MMT prevents withdrawal symptoms and drug cravings. Methadone is offered more frequently than barafine. There's a number amount between 1,614 to 1,817 prisoners that estimate 55% of prison systems that offer methadone, which is mostly used for pregnant women, acute opiate withdrawal, and chronic pain management. Prison systems do not see opiate treatment and referral as very beneficial, and they favor a drug-free detoxification. Also, there is a lack of communication between linking prison inmates to post-release providers. This survey was to pinpoint attitudes about methadone and barafine practices among state, federal, medical directors, and how widely used it is. Attitudes remain that they prefer abstinence-based drug treatment, which is having no drugs at all, a clean detoxification. But this actually ignores the reality that many relapse and then right back to prison when forced detoxification. Fewer than 2,000 prisoners in state and federal prison receive ORT, and it has improved very little since 2003 when this was approved. The cycle of reincarceration continues in most prisons. Prisons that remain on ORT upon release are more likely to keep employment and improve social function, along with breaking the cycle of relapse and reincarceration. ORT offered and practiced in prisons are very limited, and they need additional attention to help prison staff and the policymakers acknowledge the good in pharmacological treatment of opiate dependence. That's all I have for today. I learned a lot throughout this research, and I really enjoyed learning the different programs that are for women to help them have better outcomes, and also different programs that have been approved for people that are addicted to methadone and opiate dependency.